All right, Dr. Karl Nadolsky, thank you so much for coming on today.
Absolutely.
I'm so excited to sit down and chat with you about a whole bunch of stuff. Before we just jumped on here recording, I said there's a million things that I could talk to you about. I've followed you for quite some time on social media, just to give everybody kind of a background. And you and your brother, you guys are the docs who lift. So you guys see that under there if you're watching. So I followed you guys for a while. Then I found out you were here in Michigan as well, which I thought was really cool.
Yeah.
You both kind of loved muscle and bodybuilding. And that's kind of where I was, my background for a long time. And then I started to kind of follow your story about your hip, and maybe we can talk a little bit later, because that's something we have in common as well as our sad hips that try to slow us down. But before I kind of get into some of the topics that I wanted to talk about, I want to kind of talk about you for just a second, if you don't mind.
Okay. Sounds good.
Okay. All right. So first, let's explain kind of what you do. So you're an endocrinologist, obesity specialist, diabetes, hormones. So kind of explain what that is, and maybe anything else that you kind of want to let us get to know you for a second.
Yeah, sounds good. So endocrinology is the study of hormones, and clinical endocrinologists, like I am, we take care of people who have some sort of dysfunctional, hormone issue. And that could be people who have excess hormones of whatever flavor, or maybe they have a hormone deficiency, or maybe they even have a tumor or a cancer of one of the glands that has to do with hormones. And hormones are really just chemical messengers in the body that go from one part of the body to pretty much every part of the body, but sometimes very specific areas to get things done, to tell those different cells to do something. Classically, people think about our pituitary behind our eyes that comes out of our brain. That's kind of our master gland, and it makes hormones that stimulate our thyroid hormone or adrenal hormones, or our adrenal glands, our thyroid gland and our adrenal glands to make those hormones. They stimulate your ovaries and my testicles for male and female reproductive sex hormones. Then, like I said, the thyroid and the adrenal glands. Our pancreas makes insulin that has to do with glucose metabolism, glucose uptake, technically. We do osteoporosis or other metabolic bone diseases and diseases of calcium regulation. So if you know about the parathyroid glands, the little bitty guys that are in and around the thyroid area, they control our calcium metabolism. And then there's all sorts of other complicated things from there. And then, my little niche is obesity. And obesity is a very complex disease process. And as you've heard, if you follow me, that has all sorts of different little hormones involved in its regulation of our energy balance, and then the risks that come from that, especially like cardiometabolic things, type 2 diabetes, heart disease, etc.
Yeah. Very cool. And so a lot of what you talk about is obesity as a disease. And I do want to talk about that some because, I think that's a big misconception, especially in my kind of wellness and fitness space. I think you are doing a great job, and your brother is doing a great job at kind of debunking that and really helping to educate properly on that, and kind of, getting rid of some of the myths, surrounding that obesity as a disease. So you do those things; those are your specialties, and you do the podcast. And I think you show up on the podcast. Your brother actually does most of it, right?
he does all the tech stuff.
Your co-host.
I co-host it with him. There was no way I would ever do a podcast on my own because I would screw up the technicalities of it for sure. As long as he wants to do that stuff, I'm in on it. Whatever.
It's a learning curve for sure. Well, we all certainly appreciate all of the information that you guys do, because I do know that it's very time consuming to do those types of things. But I wanted to talk about really quickly too is kind of like what kind of got you into obesity medicine. Coming from, I've heard your story. Some of my listeners may or may not have heard your story. Kind of how you grew up, and you were really always an athlete, at heart, and then something got you into obesity medicine, which is not as common, again, coming from the fitness and athletic space, because it's talked about much different. So kind of what took you there? Was there any pivotal moment or
Yeah. So like you said, the background was, I grew up heavy into athletics. My parents were teachers, so we were very academic. My dad was our coach. He was a science teacher, so we were real into the biology and human physiology and all that stuff. And then I went on to Michigan State where I wrestled and I majored in kinesiology, kind of exercise physiology, included a lot of nutrition, got into the nutrition aspect because of both the science and the athletic performance part and fitness and body composition. And so that's when I really started to get into it. And then my brother was kind of following along in my footsteps in those regards. And then actually, my mom's younger sister is a cardiologist, and we were visiting her and telling her about our interests in body fat, composition, health, et cetera, talking about insulin. And she said, well, yeah, you should probably go be an endocrinologist then. And I thought, oh, okay. I didn't even know what that was. And then in medical school, you go through all the different things in the first part of medical school, and we go through the different sections, the different kind of specialties and what it has to do with. And all the complex endocrine hormone stuff, a lot of what we call negative feedback loops, where one part of the body says to do something, then that helps shut down the other part of the body kind of. And it didn't make sense to everybody. And so it's like, oh, okay, well, that kind of fits in.
Yeah.
And then that sort of, developed into my passion for helping type 2 diabetes, in addition to, already kind of being passionate about helping people with body composition issues or obesity. And then it really started to tie all together when I had some mentors who were a little bit more into the science of it when I did internal medicine residency at the Portsmouth Naval Hospital, like Norfolk, Virginia area. It was actually an intensivist, an ICU doctor who, always talked about how obesity was driving so much of the disease that would end up getting people into the ICU. And he was talking about, hey, we got to find a way to help people treat this. And it's different than what people think. And so then that got me a little bit more into the science of it. And, then Spencer and I started looking into it, and there wasn't a lot in the obesity specialization space. There were some things out there, some kind of, a little bit of quackery clinics out there and, phentermine factories. That was like the only real medicine at the time that really kind of worked, and people just kind of gave everyone phentermine, appetite suppressant. And that just got our interest into some of the developing research. It's really kind of fledgling specialty. A lot of the science is not old compared to a lot of other disease states that we have. We're always learning more about everything, right? But obesity science was really pretty new. If you look into the discovery of leptin, the hormone that comes from our fat cells and communicates with the area in our brain that regulates our energy balance and all that stuff, that's relatively new stuff. And then just more and more and more comes out. And then, all the genetics that have been discovered that drive our appetite and cravings and energy intake and metabolism. And then suddenly everything blew up and everyone was all like kind of debating all these different things. But we were already sucked into the real science and, the health issues with it. And then in fellowship for endocrinology at Walter Reed, Bethesda, I had already gotten board certified by the American Board of Obesity Medicine. So I was already kind of into that stuff. And then some of the nationally well-known endocrinologists who were obesity experts sort of took me under their wing and got me involved on a national level in some of these expert guidelines and stuff like that. And that kind of got me here, I guess. So that's a little bit of that background story.
Awesome. Yeah, I think everybody kind of has their moment. So it was your aunt, and then you got into, and then that ICU doctor kind of planted those seeds. So that's pretty cool. And it was kind of almost speaking your language at that point.
Yeah.
And again, I think that the time that we're in, and the time that you and your brother both kind of are in that internet space, it's good to see both of you again kind of debunking things. And you guys have you have good reason to be behind that and kind of debunk some of those things. So like you said, obesity itself is kind of just being studied. Really, we're kind of understanding and bringing it to us a little bit better, and kind of from a prevention standpoint and a genetic standpoint, and all of those things. And like you also talked about too, was the basics of your endocrinology is the hormones. And That's a big buzzword here
Yeah,
in
people love
wellness space.
hormones. Yeah.
They love it. And in fact, I sent out a couple emails and asked I run online workout groups as well, and then kind of in person. So this is a great time. And almost all of them were about hormones. And because I think there's so much, first of all, there's division, which I think is unnecessary.
Yeah.
And there's division within, even physicians, but there's a lot of division from the wellness space to the actual, physician space, which again, I think we're in agreement with that I don't think that there should be, but there is.
Right.
But there's so many buzzwords around. So I get a lot of questions. I have like pages of them.
Go for it.
And it's all, and I'm going to basically, what are our thyroid numbers supposed to be, and what should we get checked? And I am guilty of doing some of these things too. I have access to all of these functional medicine labs that you guys kind of talk about, and and you just, for time sensitive purposes, you guys just did a podcast on this. So I can't wait to talk about that in a second. Yeah. But I have access to all of those. But it's so misleading. And they're like, get your T3 and T4 and TSH, and then they're like HPA access and and we're like, what do you even, so there's all these questions around those things within the conversations. And basically, you can kind of talk about that. I know you'll have a lot to say, but that's kind of what the questions were, like, what actually matters.
So first of all, what are we looking for? Right. So the thyroid, the thyroid stimulating hormone, like I talked about from the pituitary, gets is regulated by something called thyrotropin releasing hormone from the hypothalamus, and this gets into the classic feedback loop that I mentioned earlier. And that thyroid stimulating hormone goes to our thyroid cells and our thyroid, and it really makes mostly T4. And it makes a little bit of T3. And then we have things called deiodinases around our body in different parts of our body that convert the T4 to T3 sort of as needed, as the body needs. And T3 is the active hormone. So I tell patients that's what gets in the nuclei of our cells and gets things churning and burning. It's our heat metabolism hormone for all sorts of things. And so, but we can have autoimmune disease, surgeries, infiltrative disease, rare things. We need iodine for our thyroid. So there are endemic areas of the world that don't have enough iodine. That's why we put iodine in our salt. So we should not have that problem in the United States. Yeah. If you ever heard of like endemic goiters where there's not enough iodine and the thyroid gets big because it's trying to keep up with it. These are all causes of hypothyroidism, which most people are generally looking for when they talk about thyroid, right?
And that's to explain. That's like when
your thyroid hormone, when your thyroid, what say that again?
So you have trouble losing weight if you.
Well, not necessarily. So hypothyroidism, this is a common misconception. It's not. It certainly doesn't help people, and it might. And we certainly look for it when people are gaining weight for no good reason. It's not a very significant cause of real obesity, though. Hypothyroidism isn't.
Okay, yeah,
there are a lot of other specific, symptoms. And so, but when the thyroid itself is not working for whatever reason, the TSH is the most sensitive marker of it, and it'll go up as long as you don't have hypothalamic pituitary disease, like tumors or surgeries or something else going on up there. And so that's why the old, doctors only check a TSH. Well, because that's the best marker. And that's what the data clearly show. And people don't realize that our lab assays are a lot more complex and imperfect than they want to think. Right. Yeah. And so, and then these labs have to be validated and correspond to disease states and what is normal, what is exactly normal, what's the bell-shaped curve of normal, and what happens if you're just outside of that normal, and where does it start to correlate with an actual disease problem. And so, in the United States, by far the most common cause of primary, meaning the thyroid itself, hypothyroidism, is Hashimoto's, which is the autoimmune cause of thyroid disease, of hypothyroidism. And so as the thyroid starts to not function well, the thyroid stimulating hormone starts to go up. And so we often will find people with what we call subclinical hypothyroidism, where if you do check that, say the T4 or the T3, and the TSH is a little bit up, but those other levels are normal, which, the wellness people might say, oh, you got to check all these things. Well, they're normal. If the TSH is up, it's more sensitive, and that person might have subclinical hypothyroidism. And then it's like, okay, well, why? Well, first of all, you always recheck it, because all sorts of things can affect are these lab assays. One, you could be sick, you could be recovering from an illness that affects all these different levels of hormones. And that's the way it's supposed to happen physiologically. And so you recheck it. A lot of times they end up just normalizing. But if they truly do have a little bit of, even if it's subclinical or true overt hypothyroidism, where the TSH is higher and the T4 is low, then they almost certainly in the United States have Hashimoto's, unless there's some other reason to think something else happened. They had radiation to their thyroid, or, they decided to go on a no iodine vegan diet, which I've seen a couple times. Or if they
no iodine vegan diet, that's the thing.
According to the patients who actually had iodine deficiency that they shouldn't have here in the United States. And so then we decide, okay, so at what point do you need treatment? Well, if they came in with symptoms that are very specifically thyroid related, and it's not just fatigue, because think about all the millions of things that can cause fatigue.
Oh, gosh.
And that's actually what our podcast recently was about. It was about a guy who, came in for fatigue, and that requires a pretty holistic evaluation. But there's certain things that need to be checked first. Pretty much thyroid's going to get checked. But anyways, it wasn't his thyroid. But cold intolerance, dry skin, brittle hair, maybe some hair loss. There's all sorts of other things, reduced bowel movement frequency, maybe weight gain a little bit, not a driving cause of obesity per se, but a little bit of weight gain or trouble losing weight, we're going to check it. And if you have those symptoms, you're going to get treated, whether it's just a supplemental dose or, really a full replacement dose of thyroid hormone. If the TSH starts getting into like the 6 to 9 realm, there are probably, even if you're asymptomatic at that point, but it's definitively sort of a subclinical hypothyroidism, there are probably long-term benefits to being optimized a little bit more. The TSH doesn't have to be 1 or 2 or 3 necessarily for the health benefits. We generally say that, like, our goals are, depending on what guideline you look at, might be, depends on the person though, 0.2 to, 2.5 for like a young adult female of reproductive age, up to 3 for most people of young adulthood. 4 really is probably fine. Actually, that's part of kind of the other end of that bell curve, because everyone's different, right? Sure. But and then if the TSH is over 10, I mean, definitively it's beneficial to treat, like absolutely, if you look at all the data.
Yeah.
And so but everyone's different. And then if it's really like a gray zone and you really don't know what's going on, it's a little subclinical, we certainly check a lot of like antibodies for the Hashimoto's to confirm it's Hashimoto's. Some people don't have the antibodies, but we can tell on an ultrasound if we do that. People shouldn't just go get their thyroids ultrasounded though, please. Then we end up getting false positives of different things. But we can look at that and tell if they have kind of a Hashimoto's.
And that's only if you, like you said, if you deem that that's necessary step for the ultrasound. Yeah,
exactly. Yeah. But there are other reasons why people get their thyroid screened. I mean, that some people would argue based on the statistics that maybe most females should just get their thyroid screened every once in a while. Some would argue that every single person who becomes pregnant should get their thyroid screened, because thyroid hormone is very important in pregnancy. And that's why we do historically have some more intensive goals. Like, we're a little bit more anal about it, making sure, we check it every 4 weeks. Historically, in the first trimester, we say the TSH should be between 0.2 and 2.5. It turns out that maybe that's not so much the case in some of the bigger randomized trials. Maybe it doesn't matter as much as we thought. If they definitely have Hashimoto's, we tend to be a little bit more anal about that too.
During pregnancy, you're saying?
Yeah, during pregnancy, yeah. So, and that's why we talk about young adult reproductive age females. But then there are those, when you hear about the T3 and stuff, there may be, 15 to 20% of people who, those deiodinases I talked about, when they're on treatment with the T4, so levothyroxine, bioidentical T4 that everyone says, is kind of the most common prescription around, right? By far, most people do fine. If you get it right, you get them to their personalized TSH goal that's about right for them, but also safe, by the way, without overdoing it. We don't want to get the TSH too low, because that means the brain is basically telling you you're getting too much thyroid hormone, and that's not good for your bones, risk of heart rhythm issues, et cetera. And those issues get more important as we age, by the way, right? Especially like after menopause and things like that. But but some people who are on treatment with just T4 monotherapy, they just don't feel right, right?
Yeah.
And there may be a little bit more to it. You know, people with autoimmune disease like Hashimoto's may have other things going on. They're at risk of other autoimmune diseases. But let's just say they have no other issues. Everything's been evaluated. They've had a truly holistic evaluation, not a BS use of the term. And, you know, their TSH is 1. They're on whatever dose of the levothyroxine, the T4. And there's really nothing else going on, but they have some of those symptoms of hypothyroidism. There may be the people who might benefit from a little bit of T3 supplementation. And the studies, they're real vague. So if you look at all the studies together, it doesn't look like there's much difference. But when you start doing sub-analyses of these studies, it's like people tend to favor it a little bit more for kind of unclear reasons. They just do. They might have a little bit better weight, not a ton, not like in the realms of obesity that we talk about, but a little bit better weight. And that stuff might matter. And so if it's safe, a young adult person with low risk of the side effects, we do a fair amount of, I prefer to give a little bit of bioidentical T3. I prefer not to use desiccated porcine thyroid that is really popular in the alternative wellness world for some reason. I think just because it has a good marketing ploy. It's natural, but it's from a pig. It has different ratios of T4, T3, even the other thyroid numbers that don't really matter, by the way. And people often have issues with that because they get too much of the T3. They get these thyrotoxic symptoms. It might not be great for them. It has less regulation, less consistency. So I usually can convince people to stick with the bioidentical stuff because we can be much more precise and personalized that way.
Yeah. And you're obviously there under a doctor's care and so you bring up, so I hear a couple of things in that conversation there, that you treat each person as an individual. Yeah. You take into account all of them as a whole, as a person, their lifestyle, maybe some genetics, their age is a big thing. You know, unfortunately, we can't prevent that.
I know. That's what I tell every patient. And they're like, maybe it's just my age. I'm like, I don't buy that. I'm not going to blame anything on age because we all seem to be getting older, which drives me crazy, but it's true.
So you do take all those things into consideration, and then you bring up holistic. So I love that, you know, you use that term, and in the proper way. And again, there's that division there where, you know, a lot of the functional medicine world and wellness space will often, you know, say, well, don't go to a physician because they'll never find the root cause. And that's just, you know, that's one of those buzzwords too. And it honestly shouldn't be a buzzword. So there's holistic and root cause that they kind of stir around, and you're like, no, listen, like they actually go to the root cause. This is the process that it actually takes.
Yeah. And the problem is our healthcare system globally in the United States, everyone knows it's dysfunctional, right? We've got issues. It's the system more than like, you know, physicians and nurses and healthcare professionals. And so unfortunately, those people have taken those terms and misrepresented them and used them as marketing to create division because, every mainstream medical school residency training program talks about holistic medicine, getting to the root cause, treating the whole person. But then they take those and say, mainstream, that's come see us, pay us all your money, and we'll do all this other stuff. And definitely listen to our podcast. And this poor guy went to a wellness clinic and they just did 100 different unnecessary tests with all sorts of bad, costs. Luckily, they didn't get any major false positives because that's what happens. If you just order tests without having a clinical consideration for what the heck you're looking for and pre-test probability we talk about on the podcast, then you're going to get false positives, false negatives, false sense of security. You might end up having more cost, going down more rabbit holes. And ultimately what they did was they didn't address the person's anemia, which is absolutely always going to be looked for when people are fatigued. And
Sure.
then there can be some really bad things that cause anemia of unclear origin. And they didn't address it. So they didn't get to the root cause, but they did tons of unnecessary things and then recommended a bunch of completely unnecessary drugs and supplements and all sorts of stuff that would cost the person several thousands of dollars. And then the person might die of a colon cancer or something.
Yeah, and not even really know if something did work,
Right.
not even know what was working, because they did that. And you brought, I did listen to that episode, and that's kind of, and again, I'm in total agreement with all of that because I see it firsthand. And but I am kind of working hands-on with patients and with personal training clients and wellness clients and all of that.
Yeah.
However, I listened to that episode and it made me think, and this is a little bit personal, it made me think about my sister. She just got diagnosed with colon cancer. They got it all. Praise God.
Yeah. Oh my gosh.
However, her main symptom was anemia.
Oh,
and yeah. And had I been that sister, because she does look to me for a lot of advice and things like that, whether she likes to admit it or not.
Yeah.
She's my older sister. Had I had said, don't go to the doctor, don't eat, just take this iron or eat Cheerios, they're fortified, or, it's your iron, they would have missed that. And honest to God, she would have died.
That's scary.
It made me think about that because there's a bunch of people that think like that. And there's a lot of, and they mean well, they want to help people. Yeah. Most of them do.
Yeah.
And in their minds, they think, that's maybe a better route. But I just thought about that and I'm like, man, if she would have not gone to the doctor, they gave her iron and it really set things off. And that's when she was rushed to the hospital and they found that, the mass and all of those things. And I'm just like, wow, fatigue was her main symptom.
Yeah.
And it was from, anemia.
Wow, this is a great step off from that podcast. I'm so sorry to hear that, but really glad she got caught. That's great. That's how it's supposed to work. And we get worried about these things being missed. And, from the thyroid world that I live in, there are definitely people who, thyroid cancer is one that we take care of in endocrinology. And I'll tell you, most thyroid cancers are not really that concerning. The pendulum has swung. The data show that, most of them are by far not a big deal. And we take care of them. We try to do as little as we have to nowadays to take care of them. But some are very dangerous. And there have been stories in, that I've experienced with some patients or my colleagues where people, they didn't want to do what was recommended. And a lot of times it might just be taking half your thyroid out. And, they went to some alternative practitioner who knows what it was, right? It wasn't even a functional physician or something, who knows what it was, but they tried all these other things and now it's spread and then it was too late. And and thyroid shouldn't even be that big of a deal. For most thyroid, there are some rare, severe thyroid cancers, of course, but,
sure. Anyways, and it gets to, and that's, I think, where it really gets to be that dangerous point. And my best friend and I are really, we always talk about this kind of stuff. And we both come from a competitive bodybuilding world and we're kind of in the wellness space. And we're both kind of on the same page with that. And it's like our pet peeve, and it does drive us crazy because we're in this space and we, of course, mean well. And, and I think, and this is another thing that we can, you and I can kind of merge into and talk about real quickly for a second. Is of course my dream is to be able to work with physicians and be that next step down for doctors, even the cardiologists that I work for. I see them only get a few minutes with patients, and luckily we have a cardiac rehab that they can refer to. However, they have to have certain diagnosis in order to be there. It's not preventative. It's not covered by insurance for prevention. But I think that that would be like the next step. And that's always, of course, a dream to be able to do that at some point. So you also kind of talk about that and bringing a kind of gym almost setting or a kind of wellness center into an office.
Yeah. It's interesting. I think, and this is another thing that's discussed in mainstream medicine. Everybody wants to have these multidisciplinary teams. It's, if you look at quote unquote, mainstream guidelines, right? And all these things that we look at, because the evidence is there. Every time it's studied, that stuff is good. And our system isn't good enough to let doctors can't do everything. And people say,
Right.
well, doctors don't know nutrition. Well, yeah, some of us happen to have a specialty in it, but yeah, that's not necessarily what you want your doctor to be an expert in. You maybe you go see an oncologist and you want that doctor to know the cancer diagnosis and treatment, right? You want that doctor to be the expert in that field. We need to do better collaboration with our healthcare team members and find a way. Insurance needs to cover more of this stuff. We need, and maybe we're shifting a little bit more that way, but it is so frustrating that we do have a dysfunctional healthcare system. It doesn't mean we don't all want kind of a very similar thing, though. We all should want holistic, multidisciplinary care. I'm very lucky that, I've been able to be involved in training and some work situations where I have great dietitians who are my diabetes educators. We're going to work on ways to figure out how can we get the exercise component covered, because that's a hard part to get covered, right? Like you just said, unless they have a reason for physical therapy or like exercise rehab of some sort, a specific diagnosis that gets covered, it doesn't get covered. And we need everyone to do exercise. I don't care what the ailment is. Everyone needs some sort of exercise prescription, and it's not great coverage. So I spend a little bit of time with every person kind of doing real basic stuff, seeing what I can give some personal recommendations. And then my dietitians do as much as the dietary stuff, and they follow them up and all that stuff. But we got to do more. And if we could have all of us in one building and a kitchen and a gym and a behavioral health setting where you can talk and actually get paid for doing the work and taking care of people, that's what we should do. And everyone knows it. It's not alternative. It is evidence-based medicine.
Yeah. And just to kind of backtrack there too, like, doctors have their space. And I hear that too, even from my own patients. Well, my doctor didn't know a lot about nutrition because they'll see my dietitian. I'm like, well, your doctor's not supposed to actually teach you about nutrition. He's supposed to recommend that you do certain things, but that's the dietitian's job. Yeah. She went to school for that.
Yeah. And we should know something. I think, we do need more nutrition in medical school, and everyone's pushing for that. I think it is happening. But some of us just happen to have that interest, right? And then when you specialize, you got to learn certain nutrition things for that whatever specialty. In endocrine, obviously, we do need to know a lot of nutrition. It has to do with from obesity, diabetes to bone health and stuff like that. So there's a little bit more of that in my specialty, but there But to be able to have that to recommend and kind of have that next step, of course, that's all of our dream. And that's kind of something that you are kind of working on, we're trying,
a little bit, and, I guess step by step, and maybe even if it's not in our lifetime fully, we can set it up for the future.
Absolutely.
Because, obviously that's extremely important.
One thing, speaking of this, I know we don't have too long to go, but that does actually remind me, how also in that world of this division, people say, oh, we have too much sick care, not enough actual like health care or wellness care. That's actually really true, but that's a healthcare system dysfunction. It goes back to how physicians, we get paid, because people were a little bit healthier, I think, from a behavioral lifestyle aspect once upon a time, right? Because we have the built-in obesogenic environment, and it is kind of acute sick care. That's how the whole healthcare system was built upon, and it's really hard for it to make this transition to a little bit more of preventive wellness, overall care. So I think there really is some truth to that. It's just we shouldn't use it as a divisive thing. I think we all know it, and everyone wants that.
Yeah, and I think there's some people that really, really feel strongly to keep that divide, because they just, for whatever reason, maybe it's personal, maybe it's something they've learned.
Unfortunately, money. There's money involved.
Well, there's money because, of course, there's the supplement side of things, like you talked about, and then there's just sometimes just some built-in general distrust now, because of that model that we just happen to have at this point. And you say healthcare and sick care and all of those things, because people don't really see you until they're sick.
Right. And that's how it historically was. And so we have to shift that. And we are. I mean, that everyone says it. Everyone talks about it. It's a big deal in healthcare, but apparently easier said than done. There are a lot of factors at play, and we could blame a lot of different groups, but we won't get into that. There's politics and government and business and pharma and everybody's to blame to some degree.
Yeah, and I think that if we spend a lot of time and energy on that, then, we miss the point of actually moving forward, in our one little town or one little building, at a time, and kind of be able to make somewhat of a wave. My program is covered most in Michigan. It's extremely hard to get things covered. That's my biggest hurdle. But my program for the intensive cardiac rehab, because it's obviously more a wellness kind of space, is that program is covered preventatively in Hawaii by Medicare.
Wow.
And in Hawaii only. So it's a start. I mean,
yeah, isn't that interesting?
Yeah, and they don't have to have, and they just have to have not simple because it's never great, but they have some risk factors. Meaning they don't even have to have obesity, but they can have a few different risk factors combined, and then that is actually a covered program. And our program, and something like what you do, in what you're talking about, is obviously could do wonders for a lot of people and educate. Not only, I've heard you talk about, couples, parents, and they get to educate their children.
Family-based, team-based stuff. Absolutely.
Yeah, so that's obviously a dream. I know we don't have a lot of time, but I wanted to talk real briefly about you guys kind of have the term exercise is medicine. Which is one of the things that really made me really intrigued and follow you guys right away. Because before I knew that I felt like that, I have genetically not that great, but I've always just loved exercise. And I always knew there was a better way. And so exercise is medicine. I'm like, yes. So let's talk about that real quickly. So there's some basic general guidelines of minutes and all of those things for exercise. But maybe take it one step further for you personally, and your brother, but I hear you talk about it a little bit more, is kind of, lifting weights and the importance of that. And even at a young age, because you have 2 young ones, and I don't think they miss the gym at all, because think you kind of, So let's talk about that real quick. Exercise medicine, kind of what the general recommendations are, and then maybe take it a step further and how you feel about like muscle in general and how that can help, because that's speaking my language, because I'm always like, let's not focus on fat loss, let's focus on muscle gain.
Exactly. And that does come to play some of the stuff we're going to talk about now that we do have therapies to help people lose a lot of weight. But exercise and physical activity, of course, in general, doesn't have to be hard exercise. And you'll see the guidelines of moderate exercise intensity, aerobic exercise,
150 minutes
than that for weight maintenance kind of thing. But that's for fitness, or 75 minutes a week of like vigorous, more intense exercise. A lot of my patients cannot and won't be able to do that, by the way. I would love for them to be able to do that. So, again, we're kind of coming back to that sick care concept, but preventive medicine, for sure, we want everyone to do that. And then weight training, you'll see, a few different things, but, 2 to 3 times a week per muscle group, very basic stuff. Right. And because we have those guidelines are really based upon all sorts of data for obesity prevention, obesity treatment, cardiometabolic health, cardiovascular health, and that sort of thing. And that's kind of where it's been situated. And then, you can split hairs for all the studies that are ever done and say, well, you can actually do too much, the ultra marathoners that get heart rhythm issues or whatever. But certainly it's, exercise is great preventive medicine for obesity and obesity related disease, no matter what your weight is,
and start slow, like you said.
And so most of my patients, they don't, a lot of them don't exercise, but so we talk about finding ways to get that non-exercise physical activity, just walking around, moving around more. And that's even made it into the mainstream guidelines, by the way. If you look at the American Diabetes Association, neat. Exactly. American Diabetes Association.
Got a name for it.
Standards of care. They talk about breaking up your sedentary time because we have studies showing the benefit. And that's literally for like glycemic control in people with diabetes. So reducing sedentary time, a little bit more non-exercise physical activity, and then aerobic physical activity. And you got to start somewhere. You got to find something somebody can do it, So, and it has to fit their personal preferences. Otherwise, they're not going to do it. So all the times it's just going for walks, but some people can't go for walks. Their knees are bad. Their back is bad. And so we got to find other ways. And then, resistance training I just think it's so important. We got to build more muscle. Muscle is metabolically healthy. Every study ever done shows that more muscle is good. And this goes from cardiometabolic health to physical functional health, even arthritis issues. Sure didn't help me with my bad hips, but that's a totally different issue. I think it's, maybe it supports me once I get my hips, my other hip replaced, I guess now. And when we talk about, obesity treatment now, you're right that aerobic activity probably wins as far as, head-to-head weight loss. In fact, my brother just did a fun debate with Dr. John Jakisik, who's the well-known exercise guru from the United States at the Obesity Society. But they both, the data obviously agree that for pure fat loss, aerobic activity is going to do better. But exercise in general isn't great for weight loss. You got to combine it with the nutrition aspects. And then that's hard because obesity kind of fights against people and makes it hard to eat well. So exercise, it really should be more focused on the health, and resistance training is important when you do significant energy restriction and maybe use medication or surgery for weight loss, because if you lose weight, you're going to lose muscle, and we want to retain as much muscle as possible. So, we're really kind of shifting that paradigm to not only including resistance training, but really making it a priority if we're doing intensive weight loss efforts. Because we want people to be functional. We want people to be metabolically healthy. And we got to keep as much muscle as we can. And resistance training is really the key for that. And exercise is medicine for so many different ailments. I think, we did a MedPage Today series on the guidelines, because everyone says, oh, nobody recommends exercise. And it's like, no, they're literally the foundation or first line in every single relevant medical guideline that you could ever find. Because it's so important for everything from pulmonary disease to cardiac disease to obesity, diabetes, arthritis, anything you can think of almost, if it has anything to do with it. So,
unfortunately, you guys don't have enough time with patients to explain all of it. And then they just say exercise. And then people that don't know or are discouraged.
And that's why we need coverage for exercise people. I mean, I love to try to give them some exercise plan, but you're right. I don't even have time for that. I come up with a few little nuggets, and I might have a little bit better background to do that than a lot of doctors for
and
people,
you hope that they, and you hope that they will stick to it to some extent, because that's the other thing is, is the compliance and of them to, and we could get into this. And again, I'm going to have you back on because there's so many things that we can talk about.
We'll have to do many more.
Yeah. But people often, they just forget what it feels like to feel good. So they don't even know what they're really going for, because they're so used to living in pain or, or what have you. And so they, that's, so you don't have the time to follow up with them all the time. To make sure that they're doing it.
And I just emphasize it's about the health, it's about those benefits, and we got to find a way to personalize it so that they can do it, because they all have barriers. Absolutely.
Yeah. And and likes and dislikes and all of those things, just like you said. So to wrap that up, you say that muscle is good. And it's not what people think. It's, and people that are listening to this, obviously, most of them know my background, and you have a very similar background as far as, athletics and that kind of stuff and building muscle. But it's not like that. It is purely for health and bone health. So not everybody, has to want to lift weights to look a certain way,
Forget about appearance. I mean, I'm vain. You might be vain. We're all vain a little bit, and it's important for mental health. But really, it's what's on the inside that counts. And we got
and it strengthens your bones, and people forget that.
And that's another big one for my patients with osteoporosis and bone disease. Very important to do resistance training, weight bearing exercise, we call it. So.
And I guess I'll end on this, because again, I could go there's so much I could talk about. At what age should kids start lifting? So
I would, we were letting my baby do pull-ups, supporting it and just kind of going through the motions. To be honest, as long as you can do it safely and help the person learn how to do it, probably almost any age. People say, well, what about weight? what do you call it?
Stunting your growth.
Yeah, well, it's not going to do that.
Yeah.
There's no such thing. I'm short because I'm short. My brother's tall because he's tall, and that's the way it is. It's not going to stunt your growth. You don't want to get hurt, but you can actually, resistance training, you can use a lot lighter weight than what your body weight is. So people think, oh, you have to do body weight exercises. Well, that's actually not true. Some people can't do their body weight, right?
Yeah,
and this goes for
true.
the youngest of the young to the oldest of the old. So actually starting with, it doesn't have to be free weights either, machines, but it has to fit them, right? And they have to not be able to get hurt. So really there's no, they just got to be able to do it. So a baby can't do it, right? I mean, like you said, we put the babies on the pull-up bar and let them do some pull-ups for fun, and we lift them up. But
so any age really,
absolutely. You got to make sure it's safe. And nobody needs to push. Nobody needs to learn how to max out. They got to learn how to do it and move their muscles.
And find a love for it.
And know that it's healthy. I beg the kids to understand that it's not just for their sports and their big muscles. It's for their health long term. Yeah.
And you're kind of setting them up. I've read studies about that kind of the sooner that they start, the better, obviously. And it's kind of an obvious thing, but and the better health outcomes, even if they stop for a while. As an adult, they're still going to have that kind of that background. And
absolutely. Prevention. Boy, if we could do primordial and primary prevention, boy, we'd be in a lot better shape. So literally.
Yeah. Fun fact, before we get off here, my son, he didn't walk until he was 18 months old or so. But he didn't have a lot of other little kids around him, but we own a CrossFit gym. And he was on the rings, so he could.
That's why he's so good at gymnastics. Yeah, I love it.
So that's why he could hold himself up for a long time on a ring before he could walk. And I always share that story. And I'm like, well, we're pretty humble with it, with like if he will go in and do kind of gymnastics-y stuff but it was that they were just so comfortable hanging around, like hanging on the rings. He just wanted to hang, and he got so much upper body strength from being little. And then I entered him in gymnastics so he could see other kids walk, and he picked up real quick. But it's like that. We just kind of put him on the rings, and so it's a fun thing. Although he's not competing in gymnastics this year because he didn't want to, but he's so good at it.
I know.
But
Trey's my son's kind of burned out from wrestling right now, so we've really pulled back from competition, but he's really good. And it's like, oh, come on, man, whatever. You don't have to compete.
It's hard.
It's fine. No big deal.
And like you said, have them find something that's fun for them. Have them, and that's kind of what I want to bring to my listeners is that it's safe for them.
Absolutely.
It's safe for them to start.
Just make it safe. Don't let them go do some big barbells or something. Little bitty barbells that you hold on to.
Right. Or they actually have, if you did want to get your kids barbells and they want to copy mom and dad, they have the really light Rogue bars. We have those.
We do tons of that stuff. Absolutely.
Well, awesome. Dr. Karl Nadolsky, thank you so much. So I'm going to link up everything here where they can find you, but if you want to tell them where you're at, you can tell them.
Well, you can find, Facebook, Instagram, Twitter, TikTok. I guess I do a little bit of that at Dr. Karl Nadolsky, and of course our Docs Who Lift podcast. You can go to Anchor or really any podcast thing that has our Docs Who Lift stuff on it. So, and
you're on Apple too. All right. Well, I'll put all that stuff up for you. Cool. Thank you so much again for the time. Again, we'll do
it again.
Yes, I can't wait to have you on again because I have so many more things to talk about. I appreciate your expertise, and I hope that everybody starts to follow you as well.
Thanks, you too.
Yeah. All right, guys. Thank you so much. Don't forget to like, subscribe, and all the things.